All right, hey everybody, Dr. Spencer.
This is Dr. David here.
Wanted to keep you guys in the loop on some of the changes that are going on, just so you guys are kind of on the same page as us.
Right. Yeah, we have a couple or one or two, right?
At least. Obviously, you guys are more than welcome to reach out to us with any questions. Everybody should have our emails. Most people have our cell phone numbers. And a much better resource might be your clinic lead and your ROC, because they can more intimately tell you what's happening at each clinic.
Absolutely.
I think one of the biggest ones is some of the changes that we're doing in blood that we're doing in clinic.
Absolutely.
No longer going to be doing D-dimers and troponins in-house. And our CBCs are going to be a send-out, so there's a 24-hour turnaround on getting them. Changes almost nothing we're doing from a clinical perspective, except these high complexity cases that probably need to happen in an ER are going to start happening in an ER.
I think one of the good things that we did that you all kind of had the feedback with about the protocols was some of these are probably outside the scope of an urgent care, and we understand that. And I think, like you said, it's not going to change because we're changing the blood work out. The protocols are still all there. There's still everything that we're following. It's still, has the back staff bought in, but the change is just going to be the taking those out of the clinic. So actually, if we look at it, all of these changes that we're doing and the things that we're mentioning are from feedback from you all and are actually there to help improve the efficiency of the clinic and to help improve the work experience of everybody involved, including the provider and the back staff.
Right. Yeah, and there's some stuff as ER doctors that we just wanted to do.
Yeah.
There's a couple labs that we were taking a loss on, knowing that we were, because we thought, well, we can just do this full workup at every clinic, and we probably need to leave some of that stuff in the ER.
Yeah, agreed.
And I think, like we said, like David said, it's going to improve our clinical flow. We can get people in and out faster. These chest pain workups where we're doing repeat troponins and stuff like that probably need to be done somewhere else. And I think from the back staff standpoint and the provider standpoint, this is going to make our door-to-door time look better, and it's going to make our day less stressful and get our patients in and out more quickly.
Yeah.
Still have the CMP in-house, and we're looking to bring a couple of the other like CBC and stuff back in a way that is a little bit easier to do in-house, like an H&H.
Yeah.
So I can tell you with CBC specifically, the reimbursement from insurance is such that we literally lose money doing every test.
Yep.
And we're in the very, very small percentage of clinics that do them in-house for that very reason.
I believe your dad, Dr. Tim, said about 94% of all the clinics in America don't even have in-house labs.
And there's a reason.
Yeah.
If you go to Coleman Carney, there's not a single one of the doctor's office where they're going to draw your blood in the office. They'll either send you to the lab or send it out. At least that's been my experience there.
Absolutely.
And so I think we're just kind of going more in line with what other outpatient clinics are doing.
Absolutely.
Still have the CMP like we talked about.
Yep.
Still going to do the H. pylori in the blood. Still going to do finger stick. But we're moving from a CLIA moderate to a CLIA waived, which, if you don't know what that means, basically our lab complexity is going to go down to not needing to keep up with a bunch of the lab policies, procedures, and inspections and stuff that was.
Which is, again, going to make a lot of people in the clinic's lives a little easier. A lot of the logs are going to go away. A lot of the controls and things that we have to do, it's going to be a little easier process setting everything up.
Right. Next thing that we're going to do is talk about our swabs. So
Ooh, I'm excited about this.
Getting rid of our current swabs. The COVID swab, the flu swab, the RSV swab, those ones are going away. And we're instead going to do a combined respiratory panel that does all of them with just swabbing the nose one time.
Yep.
So someone gets rude, they have a little cough, congestion, whatever, just like our protocols were before. But instead of swabbing them multiple times, you do one swab, take it back. There's a machine that has 4 different ports, can run 4 tests at once. You can start them all at different times. And it's going to make it easier where I just swab them once, swab their throat if I need to, run those 2 tests, and it comes back quickly. And we don't have to worry about which one are we swabbing on this one, and does it need to be molecular, rapid, and all that kind of stuff. We're just moving to a one swab model.
It's what a lot of the hospitals are doing as well. So we're kind of getting in line with some of the things they're doing. And again, like you said, from feedback from you all, I know all the swabs and the protocols, it can get a little cumbersome. So this way, one swab, one test, and you're going to have those answers the very same. We are going to have training. It will not be in person. It's going to be on a Zoom or a Teams or kind of a virtual format, but it is going to be one-on-one training with every person that's going to need to do it in the clinic.
Yeah. And everything will go live with the swabs on September 11th.
September 11th. And for the blood work, we have to remember September 1st is when we can't use that anymore, because when we do become CLIA waived, we can't bill for any of those tests.
Nor can we perform.
No, yeah, we can't use them either, because technically we're not that type of laboratory anymore.
Yeah, there's been some talk about the DME. We paused some of the DME that we're seeing just to see how much we're actually using. We're basically switching to a model where a different company basically is going to supply our DME. And so if they want to buy DME, it's cash pay. If they want us to throw a splint on them, we can still bill it to their insurance. So, you know, hey, we need to put this splint on you. Like Dr. Dave has, we need to put this posterior leg on. We can bill it to your insurance if you want. We have one that's pre-made, but those are sold cash on a different basis. And a lot of other places are doing this as well.
Yeah, very similar.
And it doesn't change what you all are doing at all. Just talking to the patients, the only difference.
Absolutely. Just talking to the patients, making sure they know the difference between the two. Some of them want the splint, some of them want the prefabs, and some are willing to pay more for it.
And that's a very high view. That's not all the details of it.
It is.
That's not going to happen overnight, but that is coming here in the near future.
Correct.
So just something to be aware of.
And just so that there's no confusion with it, the Medicare portion that we have everybody still doing with the ABN and the paper, that there's no change to that at all. That should still continue exactly how it's going.
Last thing is our checkout process. You know, we're really not doing anything new.
No,
We're doing what we've always done. For some reason, somebody last year decided to stop doing it. Turns out it doesn't make a lot of sense for them to stop doing it. So we're going back to what used to be called the super bill. We call it the checkout sheet, where our poor DOFIs are up front trying to help us check out patients, collect deductibles and stuff, and they get up there, and unless the chart's completely completed, the poor DOFI has no idea what to do.
Nothing.
And now they're getting in trouble and thrown under the bus because we're not keeping them in the loop. So this checkout paper is great because normally, as a provider, you guys know, we walk in, we say, hey, so you came in with congestion, we ran a COVID test, we ran a flu test, we ran an RSV test, we swabbed you for strep, all those are negative, seems like a simple cold, called you in some cough medicine, super one like you asked. If you get any worse, come back. I expect you'll probably feel like this for another few days. Dayquil and NyQuil are fine. Any questions for me? No. Go to the DOFI, show up, you check out. Nothing changes.
All the same.
I walk in the room, I say all of those exact things, but while I'm talking to him, we did your COVID test, your RSV test, your flu test, and your strep test. Your stuff's over at Super One. Do you have any questions? No? All right. Well, here's your comment card and your checkout paper. Make sure you give this to the DOFI so that she can check you out.
And I go straight to the DOFI, and that streamlines and helps her so much because a lot of times, as everybody knows, y'all are busy and the volumes are picking up, so we can miss things. A lot of times what was happening is we just have people walking out the door. So at the end of the day, we're paying to see patients, and that just can't continue. So this change should be something that, again, helps everybody involved so we all can help each other. Because as we all know, those DOFIs have hard jobs.
And on the clinical side, I can tell you more than one time I've seen patients in a room saying, can I go? Am I done? And actually doing this checkout paper process with them, explaining what their visit was, explaining what their diagnosis was, explaining where their meds are, is the way we should be checking out patients.
Absolutely.
I should never have a patient say, am I good to go?
Yeah.
It should be very clear to them, your visit is over, here's your diagnosis, here's what we did, here's where your medicines are, here's where you need to go next, and here's what your follow-up instructions are. And that, like David said, that's just good patient care. I think those are all the big stuff. Obviously, changes are happening. There's going to be some bumps in the road. It might be a little rocky. We're open to feedback. Anything you guys have to say that you think might improve clinical flow or some stuff we can add to our services.
Yeah.
We're bringing telemedicine back because one of our providers suggested it.
Yeah.
We're also making some other changes from some of our provider suggestions. So we're super open to whatever y'all have to say. And if you have any questions, we'd love to help you.
Absolutely.
So if you need anything, let us know.